I'm actually going to open it up to the audience now for comments and questions. People could introduce themselves. That would be great.
Good afternoon, I think. I'm Jennifer Shaw from the South Central Foundation in Anchorage, Alaska. And I have a question, Dr. Evans, following what you just said. I'm curious to know your thoughts about what research we need to do and also what funding we need to pursue to achieve some of the objectives that a population-based approach would indicate.
Well, I think there are a lot of them. I mean, one of the challenges, and let me step. I'm going to reframe your question a little bit. I think that the issue is from a, and I think of it as an administrator who's responsible for a system. I rely very heavily on research to guide my work, but I also understood that we couldn't wait for all of the research to happen in order to act. And what Mike said earlier about, we have evidence in lots of different areas. So we have some evidence around what works for different cultural groups. We have evidence around what works for people with serious mental illness. We have evidence around suicidality. I think as an administrator and both as clinicians and program administrators, it's important we have to be able to take all of that and to essentially cook. We have to kind of put things together, use our best judgments, because we won't always have the studies for the very specific individuals that we're working with. For example, in Philadelphia, we had a very large immigrant population. We had communities that didn't even have a word for mental health, right? So we know that there weren't any studies that were done for this population, and we couldn't wait for those studies to be done. So what's the research out there that's already done that we can pull on that can help inform what we do? So I think from a what are we going to do standpoint, I think that's the approach. In terms of your specific question about studies, I think you were talking about, you're the anthropologist, right? Okay. I think what you were talking about in terms of looking at different populations, I think is critical because a lot of things don't always translate. And so that's one thing. I also think that we have to do more around understanding how to implement practices. It's a huge challenge. So even when we know what works, it is really, really hard to get those things to work in real world settings because of some of the implementation challenges. So those are two areas that I think we need to focus on.
I was going to see if Julie or Marcus had anything to say. So Julie, go ahead.
I think the only thing I would add to that is the balance, what Dr. Evans is speaking about, right? Do things work in small settings, and then when you scale them up, do they actually work? I think is critical. And you want to maintain fidelity so that you're doing what you say you're doing in the way that you said you're doing it, and yet you want to have the flexibility to ensure that it fits the needs of the stakeholders to whom you're doing the intervention. I think one of the things I see in suicide prevention grants are very short term. They're very prescribed, and then what happens is often we move so far away from fidelity that then we say it doesn't work. So we try things for 2 years, 3 years, 4 years, our outcomes are kind of weak, and then we say, well, it didn't really work, and then let's go back to the closet and pull out the next suicide prevention curriculum program and plunk that in, and then we do that for 3 years, and then that doesn't work. And I find that we're in this repetitive pattern of doing that. I think one of the things that when we look at whether it's a community, and I absolutely agree about the importance of really saying healthcare is not going to solve the suicide prevention challenge in the States. It's one piece, but it is not the absolute only piece. On the community side as well, it's harder to really think about how do you implement these various types of programs with fidelity. And yet I think that's where the research has to go, is where's the balance, right? What can which part of the recipe can you change and which part needs to be faithful to the model?
Marcus, do you have anything you want to add in response to the question that was asked?
No, they were both great answers. I don't have anything to add.
Okay. All righty.
Hey there, Andrei Ostrowski here. Quick question for Marcus. Marcus, very appreciative you are sharing your experience with the criminal justice system, or that history exists. I wanted to see if you could elaborate on that experience, in particular, how what systematic barriers existed during your transition out of the criminal justice system, and whether you're seeing either personally or any people that you knew also going through that transition process that have faced barriers around getting adequate services, getting the supports you need, or even things like employment. And did that have any bearing on mental health for you personally, or with folks that you know?
Yes, it did. When doing my transition, I'm fairly just recently released from prison. I came home December 7th. I did 13 years, and I was incarcerated for 13 years. So my reentry process was very difficult. It had a burn on my mental stability and my emotional stability, because when you have that stigma or that stain on your record, or you just your person, you are oftentimes disenfranchised. So I went through a state of depression where I couldn't find a job. It was hard for me to get access to educational opportunities or housing, etc. What helped me was a strong support system, access to community-based self-help programs that I was speaking of earlier, where I was doing a lot of volunteering that involved community development. For me, that helped connect me to different associations and different institutions within my community that helped support me and help me to stay focused on my goals, as well as, of course, being employed here. This is very purpose fulfilling. While I'm in the process of helping individuals, I help myself. As we know, as I feel like everyone should know, when that's in the business of helping people, when you talk and helping them work through their problems, you gain new perspectives on your own problems. So basically, just being connected to positive individuals, mentors, being connected to community-based associations, as well as institutions like the University of Baltimore, Concerted Care Group, has helped me gain more mental and emotional stability and, stay on the road to success. The other area of that question with individuals, I think they, I can't speak for anybody else. I can only speak for myself, but I feel like they kind of suffer from the same areas. It's hard. It's really not an easy answer to that question now, I don't think. But I just feel like we should invest in, speaking of people who have been directly impacted, such as myself, I have been Concerted Care Group has invested in me to become an advocate for the issues that I once was affected by, and still are affected by. I'm dealing with it better. But I say that to say, in closing, maybe the educational training and the vocational training of some of the individuals who complete these programs and, even successfully transitioning within the programs to become peer specialists. I feel like that would help them with employment, education, vocational training, and just a sense of fulfillment. And those people will be, as well as an investment in multiple systems of care, support of these individuals becoming advocates, and of the training of these individuals. I feel like that would help other individuals transition a little more successfully, if that made any sense.
Marcus, I have to say that I'm incredibly impressed by your story and your resilience and your strength, and thanks for teaching all of us. I read a little bit about you online, and you're talking to students at school about your experience, and it's, I think your courage is really, you're a role model and a mentor for people too. So I think you're really paying it forward to other people who've had similar experiences, but also to us. So thank you very much for doing that. And I think it just highlights again the importance of everything that we do, including people with lived experience. So, yeah.
Just build on that briefly.
Yeah, can you use a mic?
Yeah, sure.
Thanks.
So, Marcus, thank you for that. For other employers in the room or folks that are listening, normally basic operations don't come up to my board, but this is something I did raise to my board's awareness, that we were hiring someone with a history in the criminal justice system. And my board, and they're thoughtful people, but the reflex was absolutely not. We don't want that liability. We're a healthcare organization. We can't have someone who recently released. But they didn't have the benefit of the data of actually interacting with Marcus and going through a pretty rigorous interview process. And what I found was I've worked with people with history in the criminal justice system, and I knew that we were actually specifically hiring for that skill set because the work that Marcus has done has led to the largest revenue growth center in our organization. And we're a for-profit organization, right? And we're here for mission purposes, but if Marcus did not have that background and ability to empathize with our patient population, we wouldn't have had that revenue growth. But I don't think a lot of employers have a physician who's worked with this workforce before making those kinds of investment decisions. And so I think if we think about scale, if there is any way to help educate employers about the immense benefit of peers, especially folks with criminal justice background, and as Marcus said, transitioning from vocational training to actual employment, there's a lot of cultural and other disconnects that exist between often employers and who they're trying to employ. I think that warrants its own workshopping, its own brainstorming. We happen to get lucky that we got Marcus and we're trying to reproduce that, but the cards were stacked against Marcus and us to make that hire. So I think it's a barrier that needs overcoming.
Congratulations on, great. I'm a big believer in what you're doing, and it's so essential for systems and for programs. And we were talking about evidence a little while ago. This is the kind of evidence that I think that we have to bring more of this type of evidence into our system, and it's consistent with what we found in Philadelphia. We had fee-for-service providers who started hiring people with lived experience, peers. They didn't get any additional money, but what happened was because they started to hire people with lived experience, people started to come and people started to stay and get engaged, and they were able to hire 40 FTEs over the period of 2 or 3 years. So they had a really large staff of people, and the economics worked. To me, that is very strong evidence, and I just want to congratulate you on taking that very bold move. And for people who are interested in hiring peers, a number of systems have gone through this. Philadelphia created a peer toolkit because what happens is people have to learn all of these things over each time. So the toolkit talks about personnel policies and those kinds of things. And so you can Google it. The acronym is DBHIDS, or Department of Behavioral Health and Intellectual Disability Services. And it's a toolkit for other systems and programs that want to hire people with lived experience. Save you a little. Good.
Excuse me, there was a CBS Morning story about 10 days ago about employers who are hiring people on the autism spectrum now and talking about their added valueness to the workforce. And I thought it was an excellent story, and I think it would be really important for us to have more stories where sort of employers talk about the added valueness of having people with lived experience. I think by not doing that, we add to the stigma, and so having peer kids talking through to employers about how exactly to do this, I think is critically important, but also talking about the successes and the resilience, because I think one of the things that we haven't talked about much here is the whole sort of recovery and resilience focus, and I think that that's really important. I know we have to stop in a few minutes. Oh, sorry, go ahead.
Hello, Jim Allen, University of Minnesota, and I would like to ask if we could talk for a little bit about this. Marcus's story, of course, is a story of resilience, but also really about some of the social determinants of this thing, suicide. And much of our conversation has necessarily been about management of the acutely suicidal individual. But as professionals, as policy people and analysts, I wonder if people could share their thoughts of what is our role in terms of, the Community Art Project. I love that work, and I love, the effort to change the narrative, the community narrative about a social problem. And what, in addition, can we be doing? What's realistic in currently in the next 5 years? Professionals and people working in this area beyond the clinical encounter can contribute to addressing these social determinants.
I think many of the suggestions were made, right? Going into churches, working with community groups. We have to find people where they're most comfortable receiving that care. The idea of peer supports. I think that, there are many great community-based programs to address, to work with people long before that they even have mental health issues, where we want people just to feel connected, because then we know once they're connected, we can begin to see if they're struggling, whether it's financially or work-wise or relationship-wise. I think part of the challenge, though, is replicating the good that we see, right? Finding these, it feels like every time we birth one of these kind of community-based programs, it's kind of a new discovery. I really think that part of the challenge is figuring out the scalability of really effective interventions or even effective programs, something that, Marcus is involved in. I'd love the where you've been hired. Let's get that into Time magazine. Let's get that into kind of other national publications so that people hear your story, hear how that's working out, because otherwise it feels very challenging for systems to know where to begin. So I think that we have many really best kept secrets that we don't do a good enough job promoting.
What I would say, a couple of things. So I've been working and thinking about social determinants as it relates to mental health now for probably a decade. And, one of the challenges is that there's not a book out. I think there's one book, but not many books. And so a lot of this work, I think we have to create. And to go back to reference to what Mike was saying, there is a lot of research on a lot of these areas. And I think those of us who are the folks who are in the trenches that are doing the work every day, I think we have to pull on that research. Let me give you an example. So we know one of the strongest determinants of our health status is social support. We know that. I got like literally hundreds of studies that show that. But most treatment programs don't deal with social support. They don't think about it. They don't talk about it. They don't try to impact on it. Now, there isn't a study that I know of where people have had an intervention around social support and looked at clinical outcomes. But I'm pretty confident that if we added that as a component to our work, it would have an impact. And in fact, I think we have pretty strong anecdotal evidence that it does. So I think that our approach to this is to use the research that's available, that's out there. There are a lot of things that we know, but I think we have to be very bold in terms of being willing to go outside of the box, color outside of the box, and to implement those things. Healthcare accounts for only 10% of our health status. How healthy we are as people is determined by things outside of healthcare. And I think the mindset shift that we have to make is we need to understand what those things are and then use our best judgment around how we can impact on those things and collect the data to make sure that what we're doing is actually effective. But I do think that there are a lot of things. And I think what Marcus talked about, those kinds of things are really, really important. How do we help create a social network for people? Because one of the biggest challenges for treating people with serious mental illness is they're often isolated, disconnected from people, from communities. And when our experience has been when we help people to make those kind of connections, it makes a big difference in their clinical outcomes. So I just think it's changing our mindset that it's not all about symptoms, it's about these broader issues that impact on our health.
Marcus, do you have anything you want to say in response to the question?
Yes, very briefly. I love the idea of the 3 concentric circles that was elaborated on earlier. I love the idea of educating the church leader, the community leader, the everyday citizen, educating them, encouraging them to educate themselves about people who are at risk of suicide, and just some basic general PowerPoints that elaborate on statistics that would help a person further or elevate the conversation on a day-to-day basis. I think a greater understanding of the warning signs would be effective. Definitely a non-judgmental discourse by way of more meetings, more workshops in the community, as well as lastly, understanding the medication that's being used. I don't believe a lot of people have an understanding of, the importance of the antidepressants that, healthcare providers provide. So I feel like, it's a lot. Mm-hmm. So I feel that's a, beginning process.
Good. Thank you very much. We're going to take one quick final question and quick responses to this question.
It's really more of a comment, and I just wanted to encourage us to look at different systems for models that might work for suicide prevention and enrolling people in mental health services. So I just wanted to quickly say that in DC, our Attorney General, Carl Racine, has actually hired people with criminal justice histories, and they're doing outreach in their communities, uncovering people who are struggling with suicidal ideation and enrolling them in services and things like that. So it's kind of interesting that the agency that prosecutes criminals has hired folks and realizes their value in reaching out to people. So I would just encourage us to be thoughtful and creative in terms of that environment and that community scan.
Thank you. Really good point. I just want to add in closing that we've sort of been talking over the past 2 days about pulling together 2 areas that have sort of stayed separate, the sort of suicide prevention world and the serious mental illness world, and talking about circles that often aren't concentric, even though the people with those problems live in a concentric circle. I think we need to pull together those worlds much more. But I think back to your question about the social determinants, because we certainly know that the social determinants, childhood maltreatment, partner violence, income, all those issues are huge risk factors. Huge risk factors. And I think we need to also interface with the child protective service people and the sort of the whole adverse childhood experiences crew. And I think what's happened is we each live in our silos and talk to each other, but people don't live in those silos. And so part of my response to the social determinants is we need to sit at tables where we're all together to talk about this, because part of that gets to the prevention issue. I mean, if childhood maltreatment is one of the biggest risk factors for death by suicide in virtually every population of every age and every gender and every race, ethnicity, but we're not doing anything to prevent that, and then we get this downstream issue, there's an issue. So I think we all need to work together on this. I want to thank the panelists very much for excellent, very thoughtful conversation, and I like how we sort of had people that represent different phases of this process and in this system and who have crossed multiple boundaries, each of you. So thank you very much, and I'm going to turn it back over to you, David.